Hello friends, I am Dr. Harsh Mathur from Om Netralay, Varanasi, India. This video contains an operative procedure meant for eye surgeons for education purposes. Viewer discretion is strongly recommended, not meant for children. So today we will be watching the magic of hydrodelineation in a soft cataract. So it's been said that soft cataracts are the hardest to manage. It's difficult to chop them, it's difficult to make a trench and divide them. So what is the best alternative that will give us consistent results? We'll watch in this video. So by now a bit of phenocane is used. The anterior capsule is stained underneath an air bubble. You need to paint the anterior capsule to get a good stain. So in managing a soft nucleus, there is no fixed dictum. You have to do it somehow. So many surgeons prefer a pre-chopper, some opt for stop and chop, some go for direct chop, some prefer to tilt the nucleus, and some prefer to bring out the nucleus and emulsify it. But in these young patients, we prefer to make a relatively small rhexis, around 5.25 to 5.5. So bringing out the complete nucleus at times is a bit tough and poses a lot of stress on the zonules. So if hydrodelineation is done, then we can easily remove the central core endonucleus, and once that is managed, the rest of epinucleus and cortical matter can be easily managed. So by now the side ports are made and the main incision, a triplanar incision, is made. Now is the time to make a capsulorhexis. So I am aiming around 5.25 to 5.5 mm of rhexis. So we have got a fairly round rhexis, and now is the time to do hydrodissection. A fluid wave goes behind. This can be confirmed by the upward movement of the nucleus, and now is the time to do a. So we have got a beautiful golden ring. Now, despite continuous hydrodissection, the nucleus did not tilt. So the next method was to do a hydrodelineation, and once it's done, now I'm trying to rotate and bring out this endonucleus up, and I'm able to do that. So this small endonucleus easily comes out through this 5.5 mm of rhexis, and now it can be easily managed without using much of phaco energy. Most of this nucleus is emulsified by gentle vacuum controlled by the foot pedal, and a moment of phaco energy is given when the hard part of it comes to the tip, and in no time we are able to emulsify the nucleus. So as we are working in the central safe zone, the endothelium is safe, the posterior capsule is safe, and this method is repeatable. And finally the epinuclear sheet is brought up and gently emulsified, and we are able to manage the soft nucleus pretty easily. Now is the time to do the cortical wash. Not much of cortex is left as we had got a good hydrodissection. A bit of primary PCO is there. We leave it as it is and do a ND-YAG later. Now is the time to inject the IOL, a wound assisted hydrophobic. Intraocular lens is injected. The leading haptic goes in the bag, and then the trailing haptic is gently dialed in. And now is the time to do a thorough visco wash. Always go behind the nucleus, remove all the viscoelastic substance to avoid post-operative intraocular tension rising. So the take-home message is, soft cataracts are the hardest to conquer. So we need to find a way to deal the nucleus which is safe and repeatable. So I find bringing out the nucleus is the best way. So either by hydrodissection we are able to take out the whole nucleus out of the bag, or tilt the nucleus and bring one pole out of the bag, or hydrodelineate and bring out the endonucleus out of the bag. I hope you like this video. Do it next time. Thanks for watching.